Colorectal cancer. Colorectal cancer is a cancer that starts in either the rectum or the colon. It's approximately 150 centimeters long, and it consists of the ascending, descending, transverse colon, and the rectum. Its major role is to absorb vitamins, water and ions, as well as the transfer of waste. Colon components consist of the mucosal layer, submucosa, muscularis, and the serosa. The mucosal layer consists of lamina propria, muscularis, mucosae, mucus above colon cells, and mycobacteria. Colon cancer is uncontrollable growth of colon cells that can later invade other tissues. A polyp is a benign growth called adenoma if big in size. Polyps are slow-growing, capsulated, and non-invasive, and develops because of possible mutations of DNA. There are 5 stages to colon cancer. Stage 0 is when there are abnormal cells in the mucosa. Stage 1, the tumor has spread to the muscle layer. Stage 2, the tumor has spread through the colon walls towards the serosa. Stage 3, the tumor has spread through nearby lymph nodes. And stage 4, the cancer cells have metastasized.
Risk factors. The most important risk factor for colorectal cancer is age. Most cases occur in patients over 50 years old and increases with every decade onwards. There's also inflammation risk factors, mainly with long-standing inflammation of the colon lining, for example, inflammatory bowel disease, Crohn's disease, and ulcerative colitis. All these patients need to be screened for colorectal cancer way more often. There's also familiar risk factors, with the risk is increased with personal history or familiar history of colorectal cancer and colon polyps, even if the connection is not hereditary or genetic. For example, if the patients have a shared exposure to environmental carcinogen or a shared diet and lifestyle. Lifestyle risk factors. We have sedentarism. If you work more than 10 years in sedentary work, it increases your risk of developing colorectal cancer by 44%. Obesity is also associated with a higher risk of developing colorectal cancer, especially after obesity surgery, which greatly increases the risk of dying from colorectal cancer. We also have smoking, with increased risk by more than 25%. Alcoholism is also a risk factor, with long-term consumption of alcohol and or consumption in large amounts, increasing the risk dramatically. Incidence. In 2012, there were over 1.3 million new reported cases worldwide. It was the 3rd most common type of cancer in men and the 2nd in women. Almost 55% of these cases occurred in the most developed countries. Despite these high numbers, colorectal cancer incidence rate in developed countries has been in a downwards trend since 1985, as you can see from this figure. 5-year relative survival rate of colorectal cancer has also increased, with 51% in the mid-1970s to 65% between 2004 and 2010. Rectum cancer, it also increased from 48% to 68% in the same time periods. This increase mirrors the medicine advances in cancer prevention, early detection and treatment in Western countries. It also explains why the incidence to death ratio in less developed countries is much higher.
Pathogenesis. Colorectal cancer pathogenesis varies according to genetic and epigenetic changes to gene expression. These changes contribute to the neoplastic transformation of normal colorectal epithelium to more advanced malignancies such as colorectal adenocarcinoma. This occurs through the activation of distinct molecular pathways that cause different genetic instabilities with varying pathological characteristics. Autosomal instability pathway, which is characterized by loss of heterozygosity by an aneuploidy. This results in defects in telomere stability, chromosomal segregation, and DNA damage response. Tumors rising from this specific pathway show mutations in specific tumor suppressor genes and oncogenes, which leads to the activation of pathways key for somatic and germline cancer initiation and progression. The second pathway is the microsatellite instability pathway, which is caused by an inactivity of the DNA mismatch repair system, leading to a 100-fold increased rate of mutation in cells in the colorectal mucosa. The third is the CpG island methylated phenotype pathway, which is an epigenetic pathway, meaning that there is a change in gene expression but not to the DNA sequence of the gene in question. Pathophysiology. The alterations to DNA by these molecular pathways causes expression of malignant proteins that can either take the form of a polyploid or non-polyploid. polypoids differ in shape, being pedunculated, which are attached to the mucosa through a stalk, or sessile, which rise directly from the mucosal layer. Polyps present in colorectal cancer often have a texture that resembles that of velvet or a raspberry, with histological hallmarks of nuclear hyperchromasia, stratification, elongation, and they can differ in type, being adenomatous, hyperplastic, or tubulovillous. Hyperplastic polyps have an abnormal enlargement of the tissue due to the rapid cellular growth within it, and non-polypoid examples are flat or ulcerated colorectal mucosa, which are harder to detect. The general morphology of these neoplasms can be the presence and degree of dysplasia, irregular contours, deformity, and uncommon depressed ulcerations, as illustrated in the CT scan.
Diagnosis and screening. The symptoms of colorectal cancer are very common, such as blood in the stools or abdominal pain, which limits the clinical diagnosis. The clinical diagnosis must be made by histopathological examination. Although screening is not a form of diagnosis, it helps in treatment and prognosis. The NIHS uses screening methods with 2 stages, and it has been proven that in UK, the screening method decreased 16% of the colorectal cancer mortality. Firstly, individuals from 50 to 74 years receive kits to perform the FOB. Secondly, if the FOB gives a positive result, the patients will have to do a colonoscopy. The FOB can check hidden blood in feces. The colonoscopy gives the doctor a perspective of the extent of injury and lets him do a biopsy.
So, treatment for colorectal cancer. The treatment is decided depending on the metastasis of cancer cells, stage of cancer, general health and fitness of the patient. The treatment is divided in 2. So early stage cancer, it's stage 1 and stage 2. They have the primary treatment is surgery, and it's called local recession, where the tumor and some healthy cells are removed, and then they are given adjuvant chemotherapy to reduce the chances of reoccurrence of the cancer. And on the surgery, the healthy cells are removed just to make sure the patient does not relapse. And then for advanced stage colorectal cancer, stage 3 and stage 4, there is a combination of treatments. So first is chemotherapy. Neoadjuvant chemotherapy is used to reduce the tumor size and the metastasis, and adjuvant chemotherapy are given after the surgery to make sure that the patient does not relapse. For colon cancer patients, surgical procedure is called colectomy, where a total or some part of the colon are removed and the 2 open ends are joined together. Palliative radiotherapy is mainly used for rectal cancer patients, and this reduces the high energy X-rays that target the cancer cells, destroying it, and damages the healthy cells, but the healthy cells can regenerate, whereas the cancer cells will not. And this reduces the pain for the patient in order to carry out the surgery. And the last one, they are called biological therapies, or it can be also mentioned as targeted therapies. And these are also given mainly to rectal cancer patients rather than colon cancer patients. And this also affects the proliferation of the cancer cells, and it reduces the metastasis.
Future research. Ongoing research about colorectal cancer tries to find ways of improving treatment and its efficacy. Screening. Recent work found that mitochondrial alteration in tRNA, which occur in developing cancers, can be associated with colorectal cancer. This could be used as a biomarker for early screening tests. Stem cells. Recent research found expression of embryonic protein crypto-1 in colorectal cancer tissues. The researchers discovered that silencing crypto-1 expression would decrease cancer stem cells growth in metastatic and primary tumors, making it a good candidate for effective anti-colorectal cancer strategies. Drug treatment. Novel novel antimetastatic compounds against colorectal cancer could act by inhibiting TGF beta signaling. It was found that the drug citalopram reduced tumor size and also reduced the number of circulating tumor cells and metastasize. It was proposed its use as a potential therapeutic option for colorectal cancer. Drug delivery. Researchers showed that coating nanoparticles with alpha enolase targeting peptide could deliver two different chemotherapeutics to colorectal cancer cells. The results extended the survival of the used mouse models.